Hello, this is my presentation for the One Health, One Medicine project, and I will be presenting on dengue. So now that we get into the background of dengue, it's a very common arboviral illness, which means it passes from an arthropod vector, in this case mosquito, to humans. There are 50 to 100 million infections per year. There are 4 serotypes. It's an RNA flavivirus. It is found in the tropics, in Asia, and in the USA. There's dengue fever, which is usually once you get one serotype. Dengue hemorrhagic and dengue shock syndrome occur once you have antibodies to one serotype and you get infected with another serotype. And then we talk about the epidemic, which is when there's an outbreak of one serotype, and hyperendemic, which is an outbreak of more than one in an endemic area. So dengue is transmitted, as we said, between mosquito and man. So once an uninfected mosquito bites an infected person, the virus incubates in the mosquito's intestinal tract for 10 days. Then it bites someone else and it gives them the infection. And we've also found that there is vertical transmission between mother and child via the placenta. The signs and symptoms: dengue has a 2 to 3 day prodromal period with chills, red mottling of the skin, and facial flushing. The facial flushing, it's been found, is very specific to dengue. There's also fever, severe bone, joint, and muscle pain, which lasts for 2 to 7 days, and it gives it the nickname break bone fever. It's usually accompanied by retroorbital pain and a biphasic rash, which occurs during the fever period and post-fever period. And some people also complain of other flu-like symptoms such as sore throat. The diagnosis: the most specific diagnoses would be isolation of the virus from biological samples. You'd be looking for antibody titers to at least one of these serotypes, demonstration of the antigen via enzyme immunoassay, or detection of viral genome sequences via PCR. In most other places, what we'd be getting would be, we'd be using the CBC, looking at white blood cell counts. You'd be finding low platelets, hemoconcentration, prolonged clotting times, the coagulation studies, low sodium, elevated urea. And you can also use ultrasonography. It's a very early predictor of dengue hemorrhagic fever because the thickening of the gallbladder wall tends to precede any vascular injuries that occur with the hemorrhagic fever. The high-risk groups would be pregnant women, persons under 15 years old, or someone who's traveling to an endemic area for the first time, because they would not have had a prior exposure to any of the serotypes. So they would be at risk of dengue fever. And those who live in the endemic area, those with an previous infection, would have already had some sort of immunity, and as such, infection with a second serotype would give them a hemorrhagic fever or a shock syndrome. So to prevent this is a day-biting mosquito, the Aedes aegypti, and so it would be best when going outdoors in the daytime to be well covered, to use DEET insect repellents, reduction of breeding spaces by using larvicides or covering of water stores, public health surveillance and public education. Spraying of cities is not very effective because that only kills the adult stage and not the larval stage that you'd want to target. So the management of this would be generally supportive care, where you do fluid replacements, fever reduction, and pain medication. You'd want to use something like acetaminophen only, because the non-steroidal anti-inflammatory drugs such as aspirin, they tend to prolong the bleeding time, and this is already a hemorrhagic syndrome, so it can actually make things worse instead of better. So that's it for my presentation. These are the references that I have used. Thank you so much for your time.